Thank you so much, everyone, for coming to spend some time with us. My name is Kelly Close, and I chair the diaTribe Foundation, which is a public health 501c3 based in San Francisco. And we're devoted to improving the lives of people with diabetes and prediabetes and obesity and advocating for action. I'm incredibly lucky to be here today with three powerhouse leaders on the science front, on the public health front. We've got an entrepreneur in our midst who is in the middle of making so much change happen at United. And I am not going to go through formal introductions, but just to say, you know, up here we've got 2 pediatricians, we have 1 cardiologist, we have 3 epidemiologists, we've even got 1 environmental scientist. These are 3 people up here who care incredibly about outcomes and how to better drive them, powered by women. I know that they share my appreciation for the incredible Milken Institute. Michael Milken himself, I'm sure that none of us has heard someone smarter talking about prevention. And I don't know if everyone was at lunch today, but there were so many very, very important ideas that I'm excited to hear our panelists talk about, and we will bring these up. We also all thank Ed Greising. He runs the Linda and Stuart Resnick Center for Public Health at the Milken Institute, and he's put together this panel with a really brilliant team. So Kathy, Ken, Stacy, thank you very, very much. I'm so excited to be starting to ask some questions. And so in the interest of time, maybe what we'll do is actually just ask Dr. Goldman to start us off. And if we're going to use a framing question here, and just to say, you know, we know this stuff is hard. We know it's not going very well in terms of public health outcomes in the United States. Why is it so hard, and what are some of the tools that would help us do better?
So, you know, I think that women play a very key role in this, and I think that our largest problem has to do with information. It is not implicit bias for me to say, because survey data show this, that more than 80% of decisions about, you know, which doctor the family goes to, when does the child see the doctor, is the treatment followed, the woman makes that decision. And I'm pretty sure if I said that on a test of implicit bias, I would come out as being sexist, but that is just the reality. That is just the reality according to surveys. And what does that mean? That means that the woman is deciding, will the child be breastfed and for how long? What kind of immunizations will be received? Will they follow the immunization schedule? When will foods be introduced? What foods will they be? And I know that one of the other panelists will talk more about food. But also, what products will be purchased in the marketplace for that child? The toys, the sippy cups, the clothing, how will they be selected? And increasingly, those decisions are not being made by the woman and the family in consultation with doctors and other experts, but rather with information from the internet. We have a proliferation of these wonderful people who I think a lot of people call them mommy bloggers, who are testing products, who are putting out information about products, informing about which products are felt to be safe and not safe. Also putting out a lot of information about immunizations. We have a president of the United States who has very recently said that the immunization schedule is not good because there are too many shots being given at once, and it's overwhelming babies' immune systems, which I hasten to say, as a pediatrician, is not the case. Okay, no way can a few little immunizations overwhelm your immune system if you really knew about the assault of antigens that we are all experiencing all the time. But that information is certainly out there. And we've seen very, very drastic consequences from some of that, like the outbreak that happened a couple of years ago at Disneyland of measles. We also see in the product choice and preference space that there's a lot of pressure being placed, for example, on Walmart, which is now banning a lot of substances from products on their shelves because of concern about the blogging, and that even if it's a fraction of the families that will avoid these products, that's a major impact for them on sales. And so, I mean, I think all of this is good. I think that it's good that there's choice. I think that it's good that there's information. But I'd like to talk more about, you know, how do we make that information more relevant, more solid, if you may, more evidence-based, more fact-based.
Yeah, and it'll be interesting to get into some of that, thinking about how consumers take information to doctors and nurses and so forth, and what's positive about that and what's challenging about that. But we'll move to you, Dariush. Is it all right if I call you Dariush? It's so exciting for me to know. So this is nutrition science. So many strides are being made because of this man. I remember the amazing celebration at Tufts when they managed to finally steal you away from Harvard. Talk to us a little bit about the barriers surrounding nutrition and what you would like to see happen as tools evolve.
Yeah, so I guess one might ask, why is a person with interest in nutrition science and policy on this panel? And it's because the food system is the single leading driver of poor health in our country and globally, exceeding tobacco smoking, exceeding air pollution, exceeding violence, exceeding almost any other cause, and yet it's almost wholly ignored by the health system. And then we have these debates in Congress, including the Affordable Care Act debates 8 years ago, which just ignore nutrition and try to, through incremental change, fix the problem when really the problem, one of the drivers is the food system. So women, in addition to their role as decision makers for health, are overwhelmingly decision makers for food. And so I think it's crucial that we fix our broken food system. We truly have a nutrition crisis. By a recent estimate that we published, there's 1,000 deaths each day from heart disease, stroke, and diabetes directly due to our food system, and $1 billion in lost healthcare costs and productivity a day. So 1,000 deaths and $1 billion a day. There's no other crisis or public health problem, or Ebola, or almost anything you can think of that approaches that scale. And so, in a complementary way to the previous discussions, I think what we know now, the science we know now about what the dietary priorities should be to fix that, can be complemented by the science for systems changes. And so I would advocate that in addition to the individual information, we need to have systems changes through changes to our worksite environments, our cafeterias, our agricultural environments, what the military served, what's served in schools, to make healthier foods the default. And that's the only way we're going to address our healthcare crisis, which is crippling U.S. businesses. There's military security, military readiness risks. There's incredible problems for equity and disparities. There's sustainability issues for the environment. All of those things actually can be addressed in 10 years, in the next 10 years. And the United Nations has declared this the decade of nutrition. They recognize the scope and scale of the opportunity here. And so hopefully we'll get to discuss some of the more specifics. I laid out a lot of things, but I think that it's, health is about the food system, in addition to other things, of course. And we need to have, evidence-based systems changes to improve a healthier food system, or we're not going anywhere positive.
Yeah, I mean, as someone who is a patient, and of course we know across the 30 million people in the US with diabetes and 90 million with diabetes and prediabetes, we know that having healthy choices be easy choices would be fantastic. So I'm really interested in what you have to say about systems, and turning to Deneen. I mean, so she runs R&D at UnitedHealth. There is amazing power here, and this is an entrepreneur who has come to United. You thought you would stay there for 3 years, right? And now you're on your
12th year.
12.
Yeah.
So talk to us about what you are the most, interested in and excited about as we think about engaging people. And
Sure. So I actually technically work for UnitedHealth Group, and that's the holding company of UnitedHealth Care and Optum. And that's important because our mission, our stated mission, is helping people live healthier lives and helping the health system work better. And as we all know, healthcare is really hard. It's complex. And so why women do the majority of healthcare and make all the decisions, I don't know, but they do. And so in my mind, the best thing we can do is to make it easier and cheaper.
James, if you don't mind, could you just move to slide 3 just for a minute, because we'll show you some of this here. Yeah.
So how do you make it easier and cheaper? I'd say the first thing is, since we're all with the exception of of 3 of you in the room, 4 of you, as we make all these decisions, it's really good if we have better data and better information from which to make these decisions. I agree that people are getting a lot more information than their friends and neighbors, but at the end of the day, I still think a lot of us want to know where can we get the best care at the right time and the right price. And so transparency will go a long way in the system. If you look in most zip codes, it's really kind of interesting, even something as elective and as commoditized as an MRI of your knee. So you're having a knee, that range in price can literally go in a single zip code from $300 to $3,000. And, you know, and I remind people that a lot of people in this country now have high deductible health plans and health savings accounts. That makes you the payer for the first 4 months. You know, so what do you want? Do you want the $300 one or do you want the $3,000 one? So I'd start with transparency. We have a completely non-transparent system at this point. Number 2, I'd say, is that we have a lot of technology. And so I know we're not going to talk about it now, later, the whole digital and just technology in general. And most of it sits outside of healthcare right now. But these general purpose technologies of various types, we really need to bring them inside of healthcare to make it easier for people, just like other industries have made it easier. I'm old enough to remember standing in line on Friday nights with my dad to get his check cashed. Now, of course, you can't even imagine not just doing it all. So in healthcare, why not use digital technologies to automate hovering, as I call it, to really help people with chronic disease, whether I'm the mother whether I'm caring for myself with chronic disease, whether I'm caring for my child with chronic disease, or whether I'm caring for my mother with chronic disease. We can make it easier for people, and I actually believe cheaper, easier, and much more consumer friendly in a very Amazon way, you know, that we all love, or you know, our Apple way, you know. We want to use that technology. We have to bring that into technology. And lastly, I'd say is stress. It's stressful to be the gatekeeper of the health. And so how do we leverage some of the evidence-based practices from academia and to spread them so that everybody has access to this? And I would absolutely agree, it starts with nutrition.
Yeah, so this is a really interesting piece about stress. I mean, obviously we all know that mental health is dramatically underfunded. I've loved hearing, I guess it's the former Surgeon General now, Dr. Murdy, talk about the importance of emotional well-being. And so I wonder how you think about that. I mean, maybe many patients aren't stressed most of the time, but the stress obviously can prompt a lot of really not so great decisions. How do you think about this?
Well, I think that the largest problem in terms of women's health and perhaps societally is depression. When you look at the dailies that are lost due to all diseases in our society, depression is near the top, and for women even more so. And depression is very difficult because people who are depressed aren't trying to get help. They're not trying to do things for themselves. And so there really is the need to do a better job of finding ways to enfold people, care around people who have depression. Because parents who are depressed, that has a terrible impact on their children, on not only the well-being, their ability to care for themselves, but also their families, and it has an economic impact that's terrible. And I do think that there's a lot of comorbidity between depression and then some of the other problems that we have with substance abuse in our society. You mentioned, trying to bring, new technologies to bear. One thing that we've been experimenting a lot within our School of Public Health, I'm sure in Tufts and other universities as well, is e-health or m-health approaches. We have people who've actually worked out programs on portable devices you can use to help you quit smoking if you want to. And that's been customized to pregnant women who are very motivated to quit, but perhaps they didn't quit before they got pregnant. And it actually also not only provides the assistance that they need, but links them with a community of other women who are quitting, who are also pregnant. And I do think that's another piece of this puzzle where the technology can help us, which is that, yes, it's true that people need the expert opinion and the fact, but they also we are increasingly segmented into communities where, what's dished out to us on our Facebook account or Instagram or Twitter or whatever, it's giving us what it thinks we want to see. And smokers see something different, by the way, than what non-smokers see. And we need to catch on to this in a way to help people who need the information, get the information that, they're in a pool where they're not going to receive that. We have to get much smarter and much more strategic about figuring out how do we get into that stream and get the information in there that people need, because they're not necessarily out there looking for it.
I guess this does bring up, though, there is some tension between standardization and personalization of care. I'm curious about, and I love hearing you really emphasize the importance of mental health. I also know, many primary care doctors who sort of don't even want to ask that question because, they only have 15 minutes with the patient, or maybe even less than that. So as you all think about healthcare teams of the future and how those might change.
Can I comment on this one? Because it leads right to the stress issue, but and how stress causes a lot of bad outcomes. So we know that in this country we have a terrible problem with prematurity, just terrible. It's embarrassing. And we're right down there with some low-income third world countries.
Absolutely.
And so, and we know particularly among minority groups, it's one of our biggest disparity in healthcare. And so, and this is an intervention that I believe goes back to stress. So the intervention is group prenatal care, randomized control trials, and showing that among low-income populations, you can reduce prematurity by 50% or 35%. I'm mixing them up now. And NICU admissions by the opposite. Now I'm mixing up the numbers, but big numbers. And I don't know, I've actually been to some of the groups, and it's really kind of interesting. It turns that, and you made me think of it, that 10, 15-minute visit that's rushed, it's cold, you're waiting in the waiting room, and then you're in the other room waiting for your visit, and by the way, you don't have any clothes on, and so it's awful. Into a 2-hour educational visit with your peers, because it's grouped by delivery date, and you can feel the stress relief. And that when I want to talk about a problem, and frankly, some of the problems they talk about are things that traditionally we wouldn't discuss with our physician, partner troubles, even smoking, because we're so judgmental. We'll say, you're still smoking. And it's interesting to see how in that room the women take on issues in their own way with each other. So that's a good example of, it is a very stressful time, it's a hard time on women. And here's a model that's out there in the it's in the published literature. Our foundation actually gave a $5 million grant to Yale to see if we could get it to scale. Because how are you going to change those? Right now, the whole country's paid on individual visits and it has a scheduling system and the doctors do what they do. And now we're going to say overnight, we were just kidding. Now we want you to do group visits because it's much more effective and much better care, and women love it, by the way. People look at you like you're crazy because how are you going to actually do that? And people who look like us don't do things like that. People who do operations, I mean, business operations, technology, people who run hospitals, the chief operating officer. And those are the kind of people we have to have these kind of discussions with, because it's one thing for us to talk about it and talk about the literature. It's another thing to execute and get those rooms built. You need a room that's big enough to hold 12 people plus the doctor, because it's still care. So those are I think the real challenge is we know there's a tangible way to reduce stress, reduce prematurity, reduce NICU admissions, save a boatload of dough. Everyone's happier, but we don't have a room.
This is an addressable problem.
Yeah, by people with different skill sets than ours. Yeah. And that's okay. We need them at the table.
I mean, I love hearing that. I say to my endocrinologist all the time, I want you to think I'm cool. So I'm actually not going to go into all of the hard stuff that's going on. Where's my CDE? Where are more nurses? Where are more community health workers and peers? And I'm wondering about how you think about this. It's kind of fashionable to talk about peer-to-peer support, and how do we see that being used, for example, on the food front? Well, Mr. Dariush, Dr. Dariush.
Well, I think I'll use your question to shift a little bit and talk about whether the health system is the right tool for most of this. And so I think that the vast majority of health-related decisions happen outside the health system. And so the health system is incredibly important. I mean, I'm a physician. I've had families who've sick. I've been sick. We need the health system. But it's like a incredibly shiny, super expensive fire engine for fires, right? It's great at putting out fires, but if you want to create a program to reduce fires in the country, you don't use the fire engines, right? You use different approaches. And so I think that people say we have bad healthcare compared to other metrics and other things. We have we don't have a broken healthcare system. We have a broken public health system. And so our healthcare system is amazing if you're acutely ill, but it's not the right system for prevention. And so I as a physician, I still think that all the focus on tinkering within the health system for prevention, tinkering within the health system with group care, and tinkering within the health system to improve health will lead to gains, and we should do it, but it's going to be incremental. It's going to be sort of around the edges. And if we really want to make a major change, we have to go outside the health system. And most of the health gains of the last century were outside the health system. So water and sanitation. I mean, vaccines are maybe the one major exception, but smoking cessation, water and sanitation, huge reductions in car accidents and fatalities from car accidents, improved air and improved water, fluoridation. So I think that I think these things are important to consider, but it's more of the same. And I'll end with an analogy that I wrote about with Admiral Jim Stavridis, who's the former NATO Supreme Allied Commander, who's now a dean at Tufts with me. We wrote a piece on soft power and soft healing. And so hard power is, people probably know, the projection of might through the military, right? And the United States and all the officers and the State Department have realized that hard power should be reserved for the last instance, for something you can go in and out, clearly defined mission. Hard powers should not be used for our major national security efforts. We should be using soft power, U.S. aid, women's rights, cultural exchanges, and so forth. So we wrote an article about the health system. Right now we have hard healing, right? We're using a technologically advanced, unbelievably well-trained force, analogous to the military, which should be used for acute crises with clear in and out strategies, and we're using hard healing to try to solve our health crisis. We need to go to soft healing. We need to go to education, women's empowerment, a better food system, public health issues for smoking and water and clean air and pesticides, an issue that you've worked on. So I think that's my, I don't want to be a politician and not answer your question, but I think that's my answer is I think that most of these things will be incremental until we really address the fundamental root causes of the public health crisis we have.
But if I may, in a sense, perhaps doubling down a bit on that, but we talk about the social determinants of health, and many think that it's a conundrum that we spend so much on healthcare in the United States and yet don't have health outcomes that are as good as many other countries, other OECD countries that spend far less per capita but have better outcomes, both in terms of preterm birth and infant mortality as well as life expectancy. But we don't spend very much on social services compared to those countries. Those countries spend far more per capita. And if you look at that as an investment that should go hand in hand, then our rate of expenditures doesn't look so handsome. Then we're not really doing as much as we think we're doing. And by failing to take care of some of those social determinants of health, we are buying a lot of expensive medical care and even emergency care, end of life care, very fancy stuff that's whiz bang and it's fun to talk about because it's so heroic. However, you'd rather not be pulling people out of the burning building, right? I mean, it's great to have the heroes that can do that, but it's even better if you don't have the building catching fire. And the best determinant of preterm birth in this country actually is your zip code. And the thing about your zip code and actually Tom Leviste, who's used to be at Hopkins, on my faculty now, he did some very elegant work that it's not just your zip code, and it's not just your race, but it's the degree of racial stratification on the block where you live, the place you live. And that is also associated with actual cortisol levels, stress. We have biomarkers that say that that kind of situation creates stress. And by the way, those biomarkers are great predictors of preterm birth. Some of the best predictors we have other than actually smoking, which is another clear risk factor for preterm birth. And that is not, those are not easy things to cure. Certainly not something that the medical system is able to cure, but it does call for us to work with communities. And I do think that interventions like group prenatal care are helpful. I think that we have to respect the fact that there are people who live in these stressful conditions who are getting pregnant and are having children. Probably a large fraction of the children being born in our country today are being born under circumstances like that. And so at the same time that we need to figure out how can we go way upstream and address those social determinants, I think it is important that today we do the best that we can to take care of those pregnant women, take care of their children, try to have the most positive outcomes possible. Because the other thing that we know is that children who are born preterm, children who are born with therefore the potential for learning disabilities and other problems are not going to have a great future in terms of their own ability to achieve. They will get pregnant earlier, they will have children earlier who themselves are likely to have the same problem. And so we have to do everything that we can to break that cycle. And so I do think these interventions are important, but I also think that we have to move well beyond that. We have to go upstream of it.
Yeah, so is it 11,000 public health students that you have at George Washington?
Oh, I wish I had 11,000. I have
undergrad
2,200. I have 2,200 students in my school, and that's a fairly big school actually.
Yeah,
but, yeah.
And certainly a lot. And maybe I'm thinking also of all of the interest at the undergraduate level in public health.
A lot of interest in public health. There is.
And to think about millennials, I mean, no one cares more about, being in mission-driven environments and so forth, but there still does seem to be some tension between, like how do you measure productivity?
Can we get to that?
Yes. So Margaret Anderson led just a brilliant panel yesterday with various leaders from healthcare and also talking about health citizenship and how do we think about that at the healthcare provider level, at the policymaker level, the public health level, et cetera. So yes, measurement. Talk to us about that.
Well, I want to talk about structure in general. So I couldn't agree more that these problems should not be lay solely with the healthcare system. That being said, we are the best funded, right? We are the best funded, and we have the operations, the technology to help, and we must partner with and bring that to the table. So as we did with the CDC, where we brought the technology system, the payment infrastructure, I call it the electricity and the plumbing, the hard work nobody wants to talk about. You can't build a house without electricity and plumbing first. You got to put it in. Let's take community health workers. Yeah. Community health workers have been doing a darn good job for 30 years, maybe even more. I've been in the business in healthcare for 30 years. But I would argue they were less organized. They were less data-driven, less measurement-driven. Where they got paid from, they were completely grant-driven.
Probably more stressed.
Very stressed. But the value they bring to society and to the healthcare system, so not just to themselves, to the healthcare system, is tremendous. And years ago, I mean, there's City Health Works, there's all of them, right? We became very impressed with the published literature, with the value of community health workers to help our communities that we live and work in. And so we have had a tremendous effort to organize that group. We now employ thousands of community health workers all over the country, and they are armed with technology, systems, so that frankly, they get the best bang for the buck. So the interventions they do are the most helpful for what people need, even down to creating a system called My Connections to address the social determinants of health, that if I have a housing issue and I don't know where to go, www, I don't know what it is, but because you can now
That's really cool.
You can categorize and systematize that so that I don't say, oh yeah, you really probably should get housing. That's not helpful. What's helpful is name, address, can I call for you? Can I take you? Do you need bus money? All that kind of stuff. That's where the rubber meets the road, but you must have those systems in order so that people can actually be much more effective, and that they're not grant driven, and that the return on investment makes sense, and frankly, everyone's good. And now we're at the point where, as an example, in Philadelphia, there's a high school for foster kids, and we're now partnering with them at the high school level to say, you would be great community health workers. Nobody understands how broken the system is better than you do. Nobody. And so now let that into their curriculum, and frankly, job placement when they get out.
Yeah. But it's not just the poor. So I'm just wondering if anybody else in this room other than I has ever been placed in a position where you need to help a friend or a relative, go on the web to enroll for their Medicare plan. Has anybody else had to do that? How easy is it to understand those plans? How easy? And for me, not very easy. And it's one thing to say, oh, just go on the web and get that information. Yeah. And I'm a fairly sophisticated consumer, and that took quite a bit of effort. And I was never even sure that we made the right choice, frankly. And so, yes, there's a lot of information out there. I think this is true also with the public housing system and almost any system that we get into, that these systems are not necessarily that easy to navigate, and health insurance, I think, being a case in point, it's just so complex, and these marketplaces and the figuring out which providers, the drugs, all of that, and even for a physician daughter to do that.
So let's jump in and talk a little more. You were talking to us the other day on our call, and by the way, we are going to open this up for questions in just a minute. So we'll look forward to you jumping in. I was just blown away, Dariush, when you were talking about nutrition guidelines and how they hadn't changed in the DPP for 30 years, et cetera. There's a whole stream here of how can we make things easier and how can we make them more practical. Like, what are the major problems there?
Yeah. So thank you for asking that question. So I think that the really amazing and fun thing about being in kind of nutrition science and policy now is the rapidity of advance of the field. It's an incredibly young field. Nutrition and chronic diseases is probably 30 or 40-year-old scientific field. And we actually now know in the next decade what to do to solve really most of the problems. And I cannot think of another problem of this magnitude for which we have a solution, right? War is an unbelievable problem. Poverty and disparities is an unbelievable problem. Prejudice is an unbelievable problem. I don't have the solutions off the shelf to fix that in a decade, but we can fix our food system in a decade. And so I think that first we have to get the dietary priorities right, but we'll leave that aside maybe for questions because that's a different issue. But in terms of the systems changes, so there's probably 4 or 5 clear levers. So we do need to use the health system. So I can think of 3 things within the health system that are crucial. So one, we have to get nutrition into the electronic health record. So the number one cause of poor health should be in the electronic health record, and if it's not tracked, it's not measured, it's not intervened upon. So that needs to be done. We need to put
on a scale of 1 to 10, like how hard is that?
Not hard, right? We just have to come up with a 10 question screener and put it in the system. Kaiser did that for physical activity with a 3-question screener. They have a physical activity vital sign. We can have a nutrition vital sign. Okay. We need to have financial incentives.
I would argue all those people that spent their $1 billion on an Epic system, and what Epic is going to charge them to put in those simple little changes. It's harder than you might think.
But with the ACA, we can set standards for it and have it done. We need to put financial incentives into Medicare and Medicaid for better eating, right? The same way worksite wellness programs reward people for physical activity. John Hancock, we're partnering with them, rewards their life insurance customers for better eating, $600 a year. Medicare and Medicaid should financially reward people for better eating. And then third, we have the accountable care organization payments coming out. Nutrition should be part of those standards. Better nutrition in the community. Those 3 things would help move the food system, the health system forward. Outside the health system, probably the biggest lever we have immediately is SNAP, the food stamps program. So SNAP is $80 billion a year, and we throw around these numbers a lot. It doesn't, $80 billion is more than NIH, CDC, and FDA combined. It's about double, right? Just for food stamps, the SNAP program, right? That is not now being used as an investment, right? We could use that as an investment to incentivize healthier foods, disincentivize unhealthier foods, bring their costs closer to their true societal costs. That would transform directly the food for 36 million of the poorest Americans and all of their neighbors. So we need to make SNAP healthier. That's a crucial thing. The military and military readiness is a lever, especially in the current administration, that has to be used. So nutrition has always been a military readiness issue. So the birth of the RDAs, the recommended daily allowances that drive all of our nutrition policy, was in 1941. Presidential order, FDR, ordered the National Nutrition Conference on Defense to figure out for war what the population needs, and so the RDAs were created. At that time focused on nutrient deficiency disease, not chronic disease. The birth of the school lunch program in 1945 was after the draft. The number one reason military recruits couldn't join the military was malnutrition, so the school lunch program was created directly because of national security. Now we have the opposite problem. 1/3 of recruits can't enroll in the military because of overweight and obesity. Within 10 or 15 years, it might be 2/3 of recruits can't enroll. And mission readiness, 700 retired admirals and generals has said that obesity is a national security crisis. So we need to leverage the military and veterans' health to have the government really recognize the magnitude of the problem and leverage a healthier food system. And then just the last thing on the list, the last thing on the list is we need to sort of create, again, money talk. So we need to create carrots and sticks, tax sticks and financial incentive discounts for food industry, agriculture, retailers, restaurants, work sites, basically the food environment to move towards healthier foods, right? It's an investment. And the really wonderful thing about this is nobody loses. Nobody loses, right? The food system can still sell food. Everybody's healthier. Disparities shrink. It's only win-win. So it's not like smoking where it's a fight to the death and we're just trying to eliminate the product. It's actually, if we can shift the food system towards healthier food, everybody benefits.
There's a lot of good that can happen.
So,
so, this being a national security crisis, like, I love it that you're saying that and that everyone up here would say that. Yeah. I guess I don't really hear so many business leaders say that. I don't hear so many political leaders saying that. I don't even know. We have tried so many times at the diaTribe Foundation to figure out in Congress and the Senate, like who has type 2 diabetes, who has prediabetes, because we do actually need more champions. And it's so funny, we'll hear, oh, there must be one. It's like one? Yeah. I mean, there must be dozens, hundreds, plus, right? And there is still such a stigma, and so I'm wondering about how you all feel about that piece of it. Social norms haven't changed as much as we might like to see.
So very briefly, so we recognize that in DC, this is absent from the conversation. Businesses get their healthcare costs. GE understood this. They looked at their healthcare costs and they started with worksite wellness. They said that's not enough. They created the Healthy Cities projects because they've realized that they've got to get their communities healthier. Nutrition is complicated, so it's usually the last thing on the list. You do smoking, you do drugs, you do physical activity, and nutrition's been the last thing on the list, but now we kind of know what to do, so we need to add it to the list. So business leaders get it, states get it, cities get it.
But
they get health, but they don't get nutrition. But I think we are trying at our school to have a new public impact initiative to create policy champions. Our title is Policy Champions. We've just hired a professor of the practice with 20 years of government experience to help lead this. We've made multiple visits to DC. There are champions in DC for this. So we're trying to help be one piece of the puzzle, a convener to have real change in DC, focused on the military and SNAP as our two big issues.
That does sound something like women in particular might be particularly excited about this.
Was the one who authored the original DPP and the ACA. There you go.
Yeah, and I think there are men who are champions, but I do think, and I think your point is well taken, that we still have too much fat shaming. There's stigmatization of obesity, and there is a lack of the kind of dialogue that you'd like to have, and that whereas I think that for many, despite the fact that the environment that has been created, or in terms of the food environment, I think is almost inevitably driven, this epidemic, along with the inactivity that's just so intrinsic to many of our lifestyles, right? And that, there's nothing wrong with anybody really, most people genetically, they've got normal genetics. I think it's normal that, when you see food in your environment, that you have the desire to eat it. And I think it's normal that when you have excess calories, you store it, because over many millennia, we had fat days and we had lean days. We stored it so that we could survive. That's how we survived. But rather than being able to view it that way, there is this shaming. And I think that is a real obstacle to a lot of the kind of honest discussions that we need, in terms of allowing people to reframe around blaming those who are overweight and obese, to really addressing the environment, the food that's in the environment, the opportunity for activity in the environment, the ethic around physical activity and exercise, whether it's in schools or in communities. All of that needs to be addressed. And that may be why policymakers aren't as open about it as you would like. Yeah. Who wants to, if you're a politician, who wants to talk about their diabetes? Who really wants to do that right now? And I mean, you've got to think about that from the standpoint of, if you were a politician, and is that going to help you get elected? Now, there are a few politicians who have done things like lost an astounding amount of weight through changing their diets and exercising, and then they make that into an issue, and they're kind of like a hero. That's a little different than, say, being Chris Christie and getting up and talking about your issue openly, which of course is obvious, but he has not done, right? And I think that's true of very many of them. Yeah. So that's another place where, not only, peer-to-peer interaction can help, but I actually think some behavioral science is needed here to begin to understand what is going on
in Congress.
No, it's because Congress members are people. And in terms of the language that we use, the communications, what are we communicating, both directly and subliminally, and how do we do a better job communicating the nature of these diseases, because they really are, diabetes really is a disease. It really is a disease state, and that I don't think that we have done a good job with that in terms of communicating in a way that, how perhaps we as medical professionals understand it, that people on the other end of it are understanding it the same way.
So maybe not yet, but the great, Stanford academic Dr. Carol Dweck, has really taught us a lot about how we think about mindset. And also, I think with social media, I mean, it is interesting, a lot more does get around among patients about, how they like to be addressed and don't like to be addressed, et cetera. But maybe this could be a bridge to the questions about data and technology. How do you see, how might data and technology, better support women making healthcare decisions?
Well, I can start.
The entrepreneur, and it would be really fascinating for us to hear a little bit about what you did before United and about on childhood obesity and so forth, if that's good.
So the short story is I trained at CHOP, and then I worked at CHOP after residency and fellowship, but because I went into administration, I ended up working in the children's ER on Monday nights clinically. And one day I noticed this kid came in, and he, in PTRs, we code everything. Everything's coded because they actually track, and they do some really good research from it. And I looked down at the injury, and I remember thinking in my mind, well, he only jumped 6 feet on the basketball, and he broke his ankle. It wasn't an athletic injury, it was a weight injury. He weighed 200 pounds and he was 10 years old. But that wasn't one of the check boxes. So I put athletic injury. So, but then I thought, isn't that interesting? I'm kind of looking around the ER and I'm thinking, wow, they're all overweight. And I was born in 1964. I remember the public pool in Philadelphia. We were all skinny minis, a good sandwich would kill us, and that's not what these kids look like anymore. And this was 2000 and something, very early 2000s. So I went back and I started researching, if some parent asked me for help, where would I send them? Where do you send kids? We know where adults get sent. Weight Watchers historically, this is back, no, too. Jenny, Craig, I found them all. And my family's not overweight, so I'd never really, I heard of Weight Watchers, but I hadn't heard of the others, but they were out there.
You didn't do this in training either.
Absolutely.
So,
There was no, in my residency,
got that
no,
in training.
right.
Let's be clear.
Nobody.
No one got that in
So
training.
my sister jokes with me about my board scores in pediatrics because how well I did until I got to nutrition. Well, it wasn't addressed. That was my excuse. But, you know.
And sorry, I forgot that's a fourth thing that should change. If we just change the boards,
Yeah.
change USMLEs,
Yeah.
change the peds, internal medicine, cardiology, but 5% questions, 10% questions about
it would get everyone's
behavior,
attention.
nutrition,
Yeah.
we'd change every
Yeah.
nutrition program overnight in the country.
So the short story
every
is
medical
yeah.
education program.
There was nothing for children. There was nothing, literally nothing. So I thought, now the internet had come out, and I knew a lot about databases and all that. And I said, wow. And I also knew that we could, because there was some work in the 1980s on child obesity, but it was a shaming issue, and nobody wanted to go to fat class, you know. So it didn't work in schools, it didn't work here. But those kids who did get services, usually, frankly, at children's hospitals, they actually did remarkably well, particularly children under 12. So I quit my job. My husband had heart failure. And I started a business in child and family weight management. The AAP had clear guidelines about what to do, but we needed to get that into the hands of consumers. And then I joined UnitedHealth Group through that acquisition. But, but it gets to the whole idea that the kids loved the technology because they could go do the program online with their coach, and the anonymity, right, and have a social peer group, and that led to the DPP, which led to Real Appeal. You know, so now we have this series of more and more populations. They're not the same. The content's not the same. How you address these populations are different. We're even finding, for example, diabetic populations in weight loss programs need a different strategy and curriculum and approach than pre-diabetic or people without sugar issues. So, but anyway, technology's out there. I don't want to take all the time, so let somebody else.
No, it's okay. I mean, I think we hear a lot as patients about, a tool butte at UCSF, you know, talks so much about the value of big data, and how about we're really not accessing any of it or looking at much at all in a very smart way. I think some of the ways that we think about patients, I mean, maybe give them a little bit more credit and, think about what data do they want. I mean, I happen to I test a lot of stuff for diabetes, but just as an example, I'm testing an app right now that tells me, this shows, like, this is what my blood sugar is going to be, over the next 3 hours. And it's sort of saying, eventually it'll be 109. That's really happy, and we know that, like, that's not most of the time where people's blood sugar is. We heard David Panzier of the Helmsley Charitable Trust this today, just talking about how 70% of the people with diabetes on insulin, type 1, type 2, aren't at blood sugars that they want to be. So this is the blood sugar, over the last 24 hours. That's not about me. That's about having information that is telling me what to do. And I do think we're trending toward better tools.
So that's the example. We talked about this before. So all this technology is out there. So we just completed a study with the Children's Hospital of Minneapolis. They care for 1,700 type 1 children in the Twin Cities. And we said, wow, if air traffic control can keep those pilots on with sensors and monitors, maybe we should leverage the same sensors and monitors to do air traffic control for these kids who, remember, they only come in average 3 times a year, 3 times. And the parents and the kids, the adolescents or the parents are making 15 to 20 decisions treatment decisions every day. So the short story is, what we did is we equipped them. They're all Bluetooth enabled now, so I didn't have to do anything. The device industry is taking care of all that. But we captured the data from their insulin pumps, their glucometers, and we fit them with Fitbit with the sleep function. And then we randomized two groups, 100 in each. And the intervention group, every day the doctors and nurses would look up, and we used Gluco, really great company. They do the middleware. They turn all that data into actionable insights, just like you see, and have done it in a very disciplined way. And the intervention was, well, if your kid is a little out of whack, and for 3 nights in a row I call you and say, hey, how's Sarah doing? What's going on? And I will tell you that so we had two groups. We had small children, I don't know, 4 to 12-ish, and then 13 to 18. Which group did remarkably well with regard to rocket down their hemoglobin A1C? The teenagers. You know why? They're on their own, man. Anybody else have a teenager? I have a 16-year-old. She knows everything. You know, so and they're on their own, and that's scary. So they are testing or not testing. That was a lot of the calls we made. She's not testing. She's not testing. She hasn't tested it in 2 days. Big problem when you have type 1, right? And or, you know, she started swimming and she's not correcting right. You know, blah blah blah. But we're going to present the findings at ADA in June. But remarkably well, now we know, and I call it automatic hovering, automated hovering, and just enough. So you only swoop in, like air traffic control only communicates with the pilot when they're a little off course. And they say, you know, back over. So you automated hover, and this was a randomized controlled clinical trial. How many people do you think said no when we wanted to enroll them? And there were criteria. How many? Anybody else do clinical trials ever? 0. You know, the parents and the mothers in particular said, help me. Help me. And, you know, one woman who works actually in my group, I didn't know her brother was in the trial. She came up to me and she said, my mother has never slept through the night since he's been diagnosed 10 years ago until this program. You know, so you realize that's how we help people. That's how we use technology and help them.
This is an awesome case study, I think, for how we can think about data and technology, you know, going to the people who need it. I mean, often it is the caregivers, even not so much as the patients, but other thoughts about data and technology.
Well, he mentioned the medical record, and that
then
we could have nutritional data in the medical record, and there's so much data in the medical record, and there's so much potential for using it. You know, you've got the zip code, you've got all kinds of information that could help you to say, you know, a woman comes in for her first pregnancy visit or first prenatal visit, this is an at-risk pregnancy or not. And to make that information not only useful for the practitioner to help to go, okay, this one maybe needs that more intensive intervention, but also for the person who provided the data. We don't provide it back to them in a useful way. Any of you who have seen, you know, the little apps that are available where you get your own medical data, well, no, that's not really, that's data, it's not information. And so we're not making good use of the information we already have, and part of it is, you know, the systems that are in place they're not good systems. There's a lot of dirty data, a lot of cost of cleaning the data if you need to use it for something, antiquated software that's the platform for those systems, a lot of things that are wrong with those systems, and a lot of things that are in it that are wrong. And I mean, I myself experienced that, where, you know, everything I've ever been seen for, a stubbed toe or whatever, it's listed on my problem list, and I have to go, no, that's not my problem anymore. That was, you know, that happened to me 3 years ago, and
you
so
need to be better engaged.
It's not. You need to be engaged.
You need to be better engaged, and I mean, maybe.
But it needs to be done in a way that it provides useful information to help us do a better job caring for people and doing prevention, which it's not done.
Dariush.
Yeah, so I can give 2 examples of technologies for better nutrition, and this is relatively new. So there should be many more, but this is relatively new. So the 2 that I think are very good and very promising are, one is UnitedHealth, which people may be familiar with. I'm on their scientific advisory board, and so UnitedHealth gives the diabetes prevention program to pre-diabetics all entirely remotely through video conference with coaches and a remote sensing scale, and their results are at least as good as in-person results, and they have the ability to continue to follow people and to track people after and give them continued follow-up. Yeah, and so I think that's one, you know, very, very nice example. And this came up on our call. The traditional diabetes prevention program diet was a low-fat, low-saturated fat diet, which is, you know, 40 years out of date. And they've, you know, I was worried in my scientific advisory board meeting with them a few months ago, that their first scientific advisory board meeting, that I was going to have to battle with them to fix that. And they'd already done it. They'd already read the literature and completely changed the diet to a high healthy fat, low starch and sugar, plenty of minimally processed food, a fantastic, you know, kind of a Mediterranean style diet, which I was really happy with. That's one example. The other example is a company called NutriSavings, which is a for-profit health benefits company that Now, NutriSavings is offered to about 1.5 million Americans through a range of different healthcare organizations. John Hancock uses them in the program I mentioned, their Vitality Insurance product. NutriSavings is partnered with pretty much every major grocery store in the country, Walmart, Stop and Shop, Safeway, all of them. If you sign up and you use your employer has to have this as a benefit, but if you sign up and have a shopper's reward card, it automatically tracks every purchase you make and gives you feedback, and it gives you scores for all of your products, and it tells you got a score of 65 out of 100 on your shopping today. This product that you got, there's this one that's pretty similar but a little bit better, and it shifts you towards healthier eating. If the employer wishes to, they give you cashback rewards. Up to $30 a month usually, and the stores give you coupons, and they've shown that the average person on their program improves their shopping score about 7% per year, which is a lot.
It's big.
Is a lot.
Is
It's
huge,
yeah.
and we can think about the payers.
So those are two. Those are two,
well.
both around 3 years old,
I love
that are
that.
really good examples of using technology.
I promised that we would open it up to questions. Are there questions out there? In the front. Thank you.
So my name is Joelle. I'm also a pediatrician for the pediatricians, but I'm coming here more as a patient and from a family where culture and food and nutrition is so intertwined. And even as a physician in my family, the only physician in my family, trying to educate around diabetes and so forth is a challenge to change dietary habits. Have there been in any of the programs you've talked about some, the way of addressing culture as a big part of all of this conversation in health?
It's a big problem, right? It's a problem in that it's not being addressed. So, but I'll tell you that like UnitedHealth, we actually own Real Appeal. So we now have 5 million people who have access to it. We have 40,000 employers paying for it. We have, we had 200,000 people go through it last year. And when you get to those numbers, what we're beginning to see? The warts. The warts. And you need to do the big data analysis, but you also need to get to those kind of numbers. Historically, the DPP had low membership because, for lots of different reasons. But now, with organized systems, a more consumer-friendly approach, et cetera, we're seeing huge numbers. We'll hit 1 million people this year. So now we'll see subpopulations, like I was taking as an example, the diabetic population is probably needs additional features, as an example, but certain ethnic groups, absolutely. The reassuring part is, as you know, minority groups were well represented in the original DPP and did well, differently. So, and I think if I remember that minorities had an easier time, did a better job with the physical activity parts of the DPP versus the nutritional parts. But, so I think that gets back to, you need different flavors of ice cream for different populations. And the elderly. In the DPP, for example, elderly, people over 60 did much better than, even though we always say 58% risk reduction, the reality was people over 60, it was a 71%, and people under 30, it was only a 21. So those kids are getting, prediabetes early or biologically different. So whether it's cultural, we have to get to those populations. Same thing for drugs, right, for everything. We have to figure out that it's not one-stop shop. I guess this is your personalization question.
Yeah.
And that we must address culturally relevant, even in the what diets we recommend. I'm not gonna. I always joke. As you can imagine, I've done a lot on healthy eating and activity when I was in the child obesity business, and I used to go and. In Philadelphia, we have a large Hispanic population. I used to just always joke by saying, I'm not here to tell you you're going to have to eat turkey sandwiches, and they would get a big laugh. But I'm going to teach you how to cook Spanish rice with half the amount of oil. So very acknowledging the food choices that are already in the culture, but still the answer is not just leave it alone. The answer is to work together to figure out better options within the guidelines of the evidence.
Yeah, and I'd add it, I think you have to dig in deep, and you work in the same community that we do, but we have found in some of the work that we're doing with some of the more recent immigrants from Central America, two things. One, that the grandmothers have a lot of influence, and they believe that a thin baby is not a healthy baby, is a baby that's at risk. A fat baby is a healthy baby. They also believe that you must give your children this, that the water is not safe, because that is not their experience from their country. The water is not safe. And so they go to the bulk grocery place and they buy the cheapest food they can get in the largest quantities, which is very high calorie, not healthy food, and then they pay a lot of money for bottled water. And that's the priority because that is their belief. And so you need to understand that, and then you need to really work with people to understand the context here, how it's different, how you can shift that spending pattern to something else. You don't need to actually pay so much for every liter of your water. You can almost get it free out of your tap.
It's so interesting. I mean, what I'm really heartened by, there is a lot here that I'm getting from the three of you on tools and how things could change. I think your question also just really does, though, go back to healthcare teams and how are we providing motivation and incentives for everyone to be able to go to medical school and nursing school and how to think about community health and so forth. So thank you for this question. This is at the heart of what we need to be thinking about as we go, as we move through thinking about the challenges at the system level. I think we heard a lot of pretty exciting stuff, though. Nutrition data in the medical records, like this is doable. This automated hovering, this brings up so much about data and technology that could happen. Again, rethinking the teams of the future and how to support women and give them the tools that they need. Not just as family members, as patients themselves, as parents, as grandparents, as employers, as leaders, and how to create the right incentives out there. Is there maybe one last thing I would hear from everyone on the panel? If there's one thing you want the audience to go away with, what would you say?
I would go back to my first point, and that it's again the information, but for us to be willing to put ourselves in situations that maybe we wouldn't feel that we're trained to be in, that are comfortable. Get outside of our comfort zone, work with communities, but also work with online communities to share and to make that information better for people.
I would say that the fundamental sort of secret or plank of public health is that it's accumulated tiny decisions that lead to health, and whether it's the safety of your chair at work, whether it's your house, whether it's smoking, whether it's putting seatbelts on your child or bike helmets on, that's the secret. It's not the big flashy activity, it's these little activities. And that we have gotten that message to people for all the things I just mentioned, right? A mother would not take their child out of their car seat for fun because the child asked for it. They're going to give them bike helmets. They're going to, put sunblock on them every time they go out for a long time in the sun and so on. Yet for nutrition, right, we haven't gotten that cultural message out there. People haven't linked that. So, bad food once in a while, bad food, it's a treat, it's not a big deal, is culturally not yet, to the same level as other public health issues. And so we have to get people to understand that, and I think healthy food tastes much better than unhealthy food, and so I don't think it's a taste issue. I think it's really, there's cost, there's access, there's education, but fundamentally there's a cultural issue that people know they're sometimes giving bad food to their families, and they think it's no big deal. And so I think that getting people to understand that the secret to a healthy life is all your little decisions every day.
Yeah. So I love that, the changing of the social norms and also making it easy for that to happen.
And then we have to work through communities. All of us, we just need to work through the communities. That's where the change is going to happen. That's where the little informal informants are, and that's where we're going to get the best results.
Yeah, working through the communities, we love ending it on that level, and I think this is also a call to action to all of us to bring it back in a couple of months and to say, so how actually will that get done? And I look forward to following up with all of you. And thank you so much for everything that you are doing in your work and in your lives to improve public health and to improve medical outcomes. Join me in thanking this panel.